Greetings, my name is Patrick Nkemba. Today I just want to make a follow-up session. This session is coming because we had history taking last time on Sunday and the session did not go well. We were interrupted, and this way has been suggested as a way that we can have our sessions recorded as well as attended to live and real time without having interactions from other people's microphones or without having network issues. So this is going to be a follow-up session as well as a trial session to look at it as a rehearsal so that we prepare for the coming session that is coming on Sunday for physical examination, where I'll just be explaining how physical examination is done, what is observed in different parts of the body, and all that kind of stuff. So be present when we'll be dealing with physical exam. For today we are talking about history taking. So this is Patrick Nkemba from Cfhs Zambia, and you have just joined the medical diagnosis program. This program we talk about medical conditions, we talk about cases, topics that affect people, and this time we are just starting the year with history taking and minor clinical procedures that we have to know before we get into conditions themselves. So history taking is one of the very important issues that you have to understand. It's a core step in medical diagnosis. Like if you want to make a diagnosis, history taking is one of the very important things that you have to put on your fingertips. So what is this history taking? History taking is a systematic process of gathering relevant information from a patient to aid diagnosis, management, and clinical decision making. So history taking is going to help you diagnose this patient, manage this patient, and make other decisions that will involve this patient, especially when it comes to counseling, what to first recommend to this patient, and what you that you have taken. So what are the components of the history taking? One of the components is that while taking history, first and foremost you should pay attention to biodata. This is taking into consideration that you have already done all the necessary things that you have to do, making sure that you put the patient in a private place where there is no noise, a conducive environment where you can be able to communicate, where they can be able to open up. That's a very important step, and we assume we've already done those, and we go direct into the procedure itself, where you begin with getting that biodata. This biodata, we're talking about the patient's name, the age, the sex, and the address where they're coming from. Sometimes you can even go beyond and get the things to do with their religion, because it also assists in other decisions that you might make on them. So that's very important. We go and talk about the second one, which is chief complaint. Chief complaint is the main reason why they have visited, the main reason why the patient has come to you. So you can ask, what has brought you today, or how will I assist you today, so that the patient can begin to talk about the main reason they have come. So when they talk about that, you can now say, put that into what is called history of presenting complaint. You ask them, when did it start? How long has it been there? Has it been progressing? Have you noticed any change? Is it growing? Is it becoming small? That is called the progression of the symptoms. So if these symptoms include pain, then you can also involve Socrates. Socrates is more like trying to talk about what is here, but it has a more systematic way that helps us to investigate pain without leaving anything behind, without forgetting any aspect. So if you are here with me and you are following me, I just want you to go and in the comment section and type Socrates. Then you can even write what it means, as S is means side. So if you know what it means, type there so that I know we are together. Even those who don't know, they can come through and they check so that we learn together. That's how it goes. Then apart from that, you can even look at the past medical history. You ask them if they had any past conditions, anything they have gone through in the past, or any chronic illnesses that they are currently being managed on, but it might not really be the reason they have come, but they've been on this thing before, they've taken these medications before, or they are on chronic they have a chronic illness, so you need to ask that question. Or if they had any past surgeries, because sometimes what they have come with might come as a result of a past surgery. So this is very important to ask. So the order does not really matter so much when it comes to this part, because you can even ask review of other system here, but it is okay to ask for it at the end. So I've replaced review of other systems with past medical history. Then we are going to drug and allergy history. So you ask them if they have taken any drugs. Then you also ask them if they are on any medication that they've been taking for a long time, not just what they have taken for this particular condition, but if they have been taking any particular drug for any other condition that is indicated in the past medical history. For example, if they are HIV and AIDS, ask them if they have been consistent with let me not say antibiotics, but ARVs. So then when it comes to that, we can also ask about allergy history. So under allergic history, we should be able to define them under drug and food allergies. So if this person has no non-drug and food allergies, then we can indicate to say there are no known for drug and food allergies. Sometimes this patient can not only be allergic to the drugs, but they can also be allergic to food. So that's why no known food and drug allergies. So go and talk about family history, health conditions in immediate family. So is there any person in your family that is suffering from this? Maybe the mother, the father, or any relative suffering from things like diabetes, epilepsy, asthma, TB. Then we talk about hypertension or sickle cell disease. So that makes a pneumonic deaths. So it's very important. That deaths is not to say they are the only conditions that might run in the family, but it's just a mnemonic that helps to screen those things, because they are common, those conditions are common in families. So that's why we ask according to that mnemonic. Then we come to the social history. We ask them the occupation, we ask if they smoke, we ask if they take alcohol, they drink alcohol. Then we also ask about other lifestyle things, what they like doing, or maybe their hobbies, because at one point these might impact the decisions they make on their health. Then the 80th one, we're looking at review of other systems. Review of other systems. These are questions that you ask about different body systems. If this person came with a cough, obviously we are in respiratory system, so we investigate the whole cough and ask about other signs and symptoms that might come with it, other associated signs and symptoms, finding out what is present and what is not. And apart from that, we can also look at other systems like the GI. We ask if they have abdominal pain, diarrhea, or anything related to. Ask about cardiovascular system, if they have been having difficulties breathing, or failing to sleep straight on the bed without a pillow, all those kind of things. There is what we call paroxysmal nocturnal dyspnea, or dyspnea itself, which is difficulties in breathing. So it's very important that we look at all those. Then we come up with a summary of relevant positives and relevant negatives. In the summary, we can write a summary to say, no, a patient who is male, 35, was seen and complained of on 1, 2, 3, and 5. Then you say uh, the patient not accepted this, denied that, just relevant positives and negative. Then you go direct to the impression. What is the impression that you have for what you've heard? What are you thinking about in mind? What is it relating to? Then you can say, okay, this is an impression of maybe malaria, or maybe impression of this kind of a condition that you've thought of, maybe diabetes. Then if you think there are more investigations that have to be done before you conclude, then you go direct to plan. Then you begin the investigation. Maybe it's malaria, you write one RDT and all that kind of stuff. So at that point it means history taking has already finished. So one thing that I want you to know before we call it a day is that a good history taking contributes to 80% of an accurate diagnosis. So if you take a very good history, it means you are 80% to an accurate diagnosis. If you fail to take the good history, it means it might even lead you to other things that the patient is not going through, but they are just within your mind because you have failed to take a good history. One of the ways to fail to take a good history is asking questions that are suggestive, or those questions we call closed-ended questions. Are you having a sharp pain? Yes. Is it on the belly? Yes. Does it radiate to the back? Yes. It means you are going to make your own diagnosis and miss out on what the patient is going through. Alright, that is Patrick Nkemba. Until next time, see you.